This is Andrea Kane, and I'm here with HIT 330 Health Information Technology. And we have been working on Chapter 2 now for several weeks throughout our curriculum. And I wanted to go through the slides one more time now that we are pretty much finished with Chapter 2, because you will be getting ready for a quiz at the end of week 3. And I just want to make sure that we have touched on all of that we need to touch on. So let me go ahead and move forward here, and let's get through Chapter 2 together. Well, maybe I will. Let's see if it'll move for me. There we go. All right, U.S. healthcare system covers a wide range of services. There's preventative care, complex procedures. It's meant to start at birth and continue through death. And the healthcare system employs an estimated 16 million workers. So lots and lots of people are involved in the U.S. healthcare system. Medical practice. You typically have a doctor that is in charge of a medical practice, or is the medical practice is built around a doctor. Examples of doctors who are practitioners include chiropractor, a doctor of chiropractic medicine, a dentist, a doctor of dental surgery or a doctor of dental medicine, a medical doctor, an optometrist, which is a doctor of optometry, an osteopathic doctor, which is a doctor of osteopathy, and that's the same as an MD. They're trained a little bit differently, but they are the equivalent of each other. Podiatrist is doctor of podiatric medicine. So you've got all of those. In a medical practice, they typically are arranged by specialty, and this gives you some examples of some specialties, whether they're medical or surgical. Nursing practice. There are different types of nurses. There are licensed practical nurses called LPNs. There are also registered nurses. It doesn't have it on here, but there's BSNs, which are registered nurses with a bachelor's degree. If you just see an RN, that probably means they have an associate's degree, because they typically have the initials BSN if they are a bachelor degree registered nurse. And then nurse practitioners are an RN, either with an associate's degree or bachelor's degree with postgraduate education. And my understanding is that you have to have your bachelor's degree before you can get that postgraduate education. So typically it's LPN, RN, BSN, and then NP, which is that nurse practitioner. Nurses can specialize just like physicians do. They can do different things. They can go and get their certification as a nurse midwife, or they can do some others. Allied health professionals. Those are people who support physicians, nurses, and physician's assistant. They receive a certificate or licensure in healthcare-related science. Typically, when you think of an allied health professional, you might think of someone in radiology, maybe a medical tech in the lab. You might think of a respiratory therapist. Technically, we are an allied health profession, and we just don't provide care, but we do support those in healthcare. 50 states, all states required licensure for some allied health professions, some. And there are significant shortages predicted for allied health professions, like physical therapists, occupational therapists, speech language pathology therapists, those types of things. So here's a list. It includes dietitians. HIM is on there. We are not licensed, but we are certified. But that is not required. It's a state-to-state requirement. And do you know Iowa does not require that we be certified? And in Missouri recently, they were trying to get the legislature to change the verbiage to take away the requirement for certification, which I think is really sad, because our certification sets us apart. It shows that we have pursued education and experience and passed a national exam, that we have a level of proficiency that is beyond someone who has not done those things. So, occupational therapy, physical therapy, respiratory therapy, talked about all of those. Occupations, this is a good graphic to show you some of the largest occupations in healthcare. Organization and operation of modern hospitals. All right, modern hospitals. Many of them are what are called integrated delivery systems. And that includes, they are not only at hospital, but they have physician offices, they have clinics, they may even have a long-term care facility. They may have multiple hospitals, they may have rural clinics, they may have all sorts of things, and that's all their integrated delivery systems so that they can have a continuum of care. An integrated delivery network involves multiple systems, and right now health expenditures are around 3.5 trillion a year, which is 17.9% of the total American economy, which is not a good thing. Hospitals have to have an organized medical staff, provide permanent medical staff, offer around-the-clock nursing service, and provide diagnostic and therapeutic services. Acute care hospitals are short-term care provided to diagnose or treat illness or injury. So again, it talks about the hospital, that they have to have an organized medical staff, provide that the permanent inpatient beds that they were licensed for. They have a number of licensed beds by the state. That's different than the number that they staff, though. It's usually a lot less, or I'm sorry, a lot more than what they staff. They usually don't staff as many licensed beds as they have. They have to offer round-the-clock nursing services and provide those diagnostic and therapeutic services. Their average length of stay is 25 days or less. So commit that to memory. In acute care hospital, the average length of stay is 25 days or less. And it's actually significantly less if you want to know the truth of it, but that's just the general rule for a hospital. It does include long-term acute hospitals. There are such a thing as a long-term acute care hospital, and it provides inpatient and outpatient care. And again, bed capacity is licensed versus staffed. They care for adult and pediatric patients. Types of services, sometimes there's rehab, psychiatric care, general, specialty. Types of patients served, wide variety, depends on the hospital. Hospitals can be for-profit or not-for-profit. One is not better than the other. Having worked for both, there are pros and cons. If both hospitals don't make a profit, they will not stay open. Hospitals are a business. They have to make a profit to keep the doors open. When you think about the increases in drug costs, pharmaceutical costs every year, labor costs, technology costs, equipment costs, energy costs, all those types of things, they have to make a profit in order to keep their doors open and provide services to the community. Hospitals cannot give free care. At the end of the day, they have to make enough money to cover what care they do give away for free. Types of ownership can be government, proprietary, or voluntary. There are hospitals called safety net hospitals. They have a large number of inpatient stays paid by Medicaid or uninsured. Likely to be a teaching hospital. They have a large number of inpatient beds, and about a third of them are located in large metropolitan areas. Critical access hospitals, however, are different. They are paid a separate payment based on reasonable costs. They have to be located in a state that accepted a grant under the Medicare Rural Hospital Flexibility Program. The hospital itself has to be located in a rural area. They have to furnish 24-hour emergency care services, maintain no more than 25 inpatient beds, have an average length of stay of 96 hours or less per patient, be located more than 35 miles from any other hospital, and be certified as a critical access hospital prior to January 1st of 2006. And there are over 80 of these in Iowa, I believe. Organization of hospital services, you have the board of directors, a professional medical staff, executive administrative staff, medical and surgical services, patient care or nursing services, diagnostic, rehab, support services. This is a great visual to kind of show you where they're at and where they're located. HIM can be under the CFO, the CIO, or the COO. I have been under all of those in my career. So even though they show it under the Chief Information Officer, these days you're more likely to find them under the Financial Officer or under Revenue Cycle, but they can also be under the Chief Operating Officer. I've also worked for legal counsel. I have as a director, and I have worked for, what's the other one? I'm losing it at the moment. Sorry about that. All right, well, anyway, moving on. Board of directors, their primary responsibility is for setting the direction of the hospital. They have to give a strategic direction, set the mission, the values, establish bylaws based on legal and licensing requirements, select a qualified administrator, the CEO. That is what they do. They approve organization and makeup of clinical staff and monitor quality of care. The medical staff diagnose and treat patients. They have clinical privileges. They have a classification, officers, and bylaws. The administrative staff of a hospital include the CEO, CNO, COO, CIO, CFO, and the CMO. I don't see him on here. Oh, that's the other one I reported to. CMO, Chief Medical Officer, which is typically a physician, which is over medical staff and can be over medical records. So CMO was the one I was forgetting. Sorry about that. All right. And that's this again. Not sure why it's there, but okay. Patient care services. Most care provided by nurses. Nursing services include case management, patient assessments, care plans, evaluate appropriateness of the treatment, and the effectiveness of the care. There must be a chief nursing officer. Diagnostic services are provided by allied health professionals, but also radiologists, and who review the films and all of that. But there's clinical lab services, radiology, nuclear medicine. Rehab is dedicated to eliminating a patient's disability as fully as possible. You have physicians, nurses, occupational therapists, physical therapists, respiratory therapists, and speech therapists. Sometimes you have musical therapists, sometimes you have others that are involved as well. Ancillary support services, you can have the pharmacy department, food and nutrition services, HIM is mentioned here as an ancillary support service, social work, social services, that's often under nursing, patient advocate, environmental, purchasing, central supply materials management, engineering, and plant, not plan, plant operations. Admissions, central registration is pretty much under revenue cycle or the CFO. Claims and billing, same thing. Accounting. Information systems or services. Human resources, public relations, fund development, or the foundation. You might hear of a hospital foundation that's there. And then marketing. Managed care has come along, and it is a generic term for healthcare reimbursement system that manages cost, quality, and access to services. There are some types like HMOs, PPOs, point of service plans, and I think you covered all of that if I am not mistaken. And what week was that we talked about that? I believe we did. Please tell me we did. If not, we will. Anyway, they control costs, access, and promote high quality. They negotiate fees and control access to care, and they require a premium. Accountable care organizations are a partnership between hospitals and physicians. There are three models. There's an MSSP program, Medicare Shared Savings Program, that gives fee-for-service providers an opportunity to become an ACO. I've been a part of one of those before. There's an advanced payment ACO model designed as a supplementary incentive program for selected participants, and then Pioneer ACO models that were early adopters that coordinated care. That model has closed, so you can't be a part of the Pioneer ACOs. That closed a long time ago. But you can still set up an MSSP ACO, I believe. Other types of healthcare services, there's private medical practices, Medicare, primary care, medical or surgical specialty care, freestanding office settings. Medical homes, have you ever heard of a medical home? Patient-centered medical home, PCMH, those are big now. It's a model of primary care. It's comprehensive, team-based, coordinated, accessible, and focused on quality and safety. You basically go to your medical home for everything, and they screen and they help you, and they coordinate your care and all of that to make sure that you're getting what you need, but you're doing it in the most appropriate setting level. Hospital-based ambulatory care services, those include ER and trauma care, outpatient surgical services, and diagnostic and therapeutic services provided on an outpatient basis. There's community-based ambulatory care services. That's where you get into your freestanding ambulatory care centers or ambulatory surgery centers. Public health services, HHS is the principal federal agency that ensures health and provides essential human services. There are 2 units you need to know about in HHS. One is the Office of the Surgeon General. The other one is the Office of Disease Prevention and Health Promotion. Those are part of public health. So if you're thinking about public health, think HHS and think Office of the Surgeon General and Office of Disease Prevention and Health Promotion. All right, other types of healthcare services. There's home care services. It's the fastest growing sector to offer services for Medicare recipients. You have voluntary agencies that provide healthcare planning services, usually at the local level and to low-income patients, like a community health center. You have subacute care, offers patients access to constant nursing care while recovering at home. That's your home health agency. Long-term care or skilled nursing care or intermediate care facility, those are all long-term care. Care is rendered in a non-acute care facility to patients needing inpatient nursing and related services for more than 30 consecutive days. There are types of long-term care, including skilled nursing facilities or SNFs, nursing homes, rehab hospitals. They are mainly rehabilitative and supportive. Note, they are not curative. So looking in the continuum of care, people are living longer. You have the very, very, very large baby boomer generation that's now entering the long-term phase of continuum of care. And you have your typical continuum of care is primary care provider in the hospital, home care, a skilled nursing facility. Delivery of long-term care services, you have those skilled nursing facilities or SNFs and nursing homes, residential care facilities. There's also hospice, and that's provided to patients with terminal illness of a limited life expectancy of 6 months or less. And there's also palliative care. Palliative care is very helpful for those who have chronic diseases and may have a lot of pain associated with them or difficulty. Palliative care can give them relief. It's different than hospice. Hospice is really dealing with that end of life situation for the patient and family. Hospice can be in a hospital bed, in a hospital unit. It can be in a hospice facility. It can be provided at home. It can be provided in someone's assisted living room. Those are all types of hospice programs. Hospice can also be involved in skilled nursing facilities, come in and work with them. There are also adult daycare programs. Behavioral health services, you have traditional long stay state institutions that used to be used. Almost all of those are gone now. There are very few of those left. Current programs look at long stay. The current programs are no longer long stay state institutions. They're residential treatment centers, they're day hospitals, they're outpatient centers. The long stay state institutions are almost all gone. Insurance coverage has lagged behind other care for behavioral health services, and that's caused a lot of issues. A lot of people who have needed help have not been able to get it. And even now, it's very, very difficult, and the reimbursement is nowhere near what it needs to be for people to receive the behavioral health care that they need. Biomedical and technological advances in medicine, you can go to the National Institutes of Health and look at their roadmap. They're trying to accelerate biomedical advances, create effective prevention strategies and new treatments, bridge knowledge gaps. They're using telehealth, and prior to COVID, telehealth was not all that widely used. It was growing, but COVID really forced telehealth to become common. And then you can talk about EHRs, electronic health records, health data, and how that is having an impact on the delivery of health care. Talk about big data and data being used to develop new treatments, and how there is an increased need for security and data protection when it comes to electronic health records. All you have to do is go in and to the Office of Civil Rights and look at the breaches that have happened with electronic health records to know that there is a need for that security and data protection. Healthy People 2020, formerly Institute of Medicine. This would be a really good one for you to go and look at. If you haven't already, you will before you graduate this program. The goal is a society in which all people live long, healthy lives. And it lists here the goals and the social determinants of health. National Academy of Medicine reports, again, you want to go out and take a look at this, especially To Err is Human. You will read that before you finish this program for sure, and probably a couple of the others. You need to understand about where medicine has been and where it's going, and why there has been such an issue with quality in healthcare, and how many hundreds of thousands of people, millions now, have perished because of errors. CDC, that really came, you've really heard about CDC during COVID, didn't you? They're a great place to go out and take a look at their website, and you will have to do that for assignments, if not in this class, in the future. It's the leading federal agency charged with protecting public health and safety through the control and prevention of disease, injury, and disability. There are local, state, and federal policies that all govern healthcare and healthcare providers. There is a patient-centered outcomes research institute that is working on using comparative effectiveness research to make knowledgeable healthcare choices. You have the Social Security Act of 1935 looking at old age and unemployment programs. Then you have the Public Law of 1965 that amended that Social Security Act. Medicare was originally designed for people 65 years and older. It has expanded to include those willing to pay the premium who are younger than 65, those who are disabled, and those with chronic kidney disease, or CKD, or end-stage renal disease. Medicaid was originally designed for the indigent, which means poor. Medicaid has expanded to include poor children, the disabled, pregnant women, and very poor adults. Medicaid joint program with state and federal government. Medicaid is a joint program with state and federal governments. Both pay for Medicaid. The federal government provides some of it, the state has to pay for the rest, and that's how Medicaid gets covered. Medicaid provides inpatient, outpatient services, lab, x-ray, test services, physician services, nurse facility care for those over the age of 21, family planning, and 31 optional programs. Public Law of 1972 mandated utilization review for Medicare patients at hospitals and extended care facilities to make sure that they were there was appropriate utilization, and now also includes Medicaid. Established professional standards review organizations, or PSROs, who do professional reviews and evaluate patient care for necessity, quality, and cost effectiveness. Then you get to the Utilization Review Act of 1977, mandated continued stay reviews for Medicare and Medicaid patients, and to determine whether or not it's medically necessary for a patient to be hospitalized and to remain hospitalized. Then you've got Peer Review Improvement Act of 1982, where the PSROs changed to peer review organizations, or PROs. Looked at medical necessity, appropriateness of admissions prior to admission, and then changed the name to Quality Improvement Organizations. So PROs went to QIOs. Tax Equity and Fiscal Responsibility of 1982 called for gradual implementation of prospective payment systems for Medicare reimbursement. And the prospective payment system is a predetermined level of reimbursement established before the service is provided. So make sure you know that. The Prospective Payment Act of 1982 and Public Law of 1983 created DRGs, and you will hear lots about those as you go through this program for inpatient hospital care. And each case is assigned to a DRG based on the patient's diagnosis at the time of discharge. Hospital Insurance Portability and Accountability Act, HIPAA. Notice HIPAA. There are no two P's in HIPAA. Only one P, two A's. I emphasize that because I can't tell you how many times I have to remind students it's HIPAA, no two P's. We, at least in the HIM field, should be spelling this correctly. Talked about health insurance after leaving employment, national standards for electronic transactions, national identifiers for providers, health plans, employers, privacy, security, and then a healthcare integrity and database protection database. Then you have ARRA of 2009, and that includes the High Tech Act, and you will be learning lots more about that as well. Government involvement in standard development for exchange of health information, strengthening privacy and security standards, and made the ONC office, ONC for HIT, a permanent office. All right, then you come to 2010, you have the Patient Protection and Affordable Care Act. Provisions include Medicaid expansion, creation of health information, health insurance exchanges, regulation to prevent health insurers from denying coverage, requirement for health insurance with tax penalties for those without insurance, and penalties to employers that don't offer affordable coverage. But it excluded small employers. And that is all for chapter 2, and that is a lot. And I'm sorry I flew through it, but hopefully we covered everything. There is a test quiz at the end of week 7, so study up for that. You'll need to know what's in your book, especially for that quiz. So study chapter 2 really thoroughly. And that is it. I hope you are having a great week. I hope that your week ahead goes well. And next week will be week 8, and we will move on to chapters 3 and 4. So get ready to start moving very quickly through material. Take care.